thalassemia. So by definition, thalassemia is a genetic disorder. It is caused by mutations that affect the globin chain component of the hemoglobin tetramer. These mutations result in reduced or absent synthesis of one or more globin chains. So the origin of the term thalassemia, so this is derived from a Greek word, thalassa, which means great sea. This is named due to the high prevalence of the disorder in the populations around the Mediterranean Sea. For clinical forms of thalassemia, there is a wide range of severity. Some mutations may cause no symptoms or anemia, while others can lead to death in utero before they're even born, childhood death, and even early adulthood death without proper treatment. Thalassemias are classified based on which globin chain is affected. So there is alpha thalassemia. So this is decreased or absent alpha globin chain production, and beta thalassemia, and this is decreased or absent beta globin chain production. If you're in my class, this will be a video for you to watch. For the incidence of thalassemia, so about 5% of the world's population are carriers for the alpha thalassemia, and about 1.5% for beta thalassemia are carriers. There is high prevalence in certain regions. This is especially common in Mediterranean, Middle Eastern, African, and Southeast Asian populations. There does seem to be a relationship with malaria, as it does have a geographical overlap. So the distribution of thalassemia carriers closely coincides with malaria endemic regions. There is a protective effect, so studies suggest that alpha thalassemia carriers have a decreased risk of severe malaria. So this is actually an example of balanced polymorphism, where a harmful allele is maintained in the population due to a survival advantage against another disease. There are different categories of thalassemia as well, as mentioned before, so we have the beta and alpha. So beta thalassemias by definition is a group of disorders caused by reduced or absent production of the beta globin chains in hemoglobin. For the genetic origin, this arises from mutations in the beta globin gene cluster, which is located on chromosome 11. For types of beta globin genes that are affected, so we have hemoglobin B gene is the main gene involved. Mutations may lead to beta thalassemia, which complete absence of beta globin production, or beta plus thalassemia, which is reduced but not absent beta globin production. For alpha thalassemia, by definition, it is a group of disorders due to reduced or absent production of alpha globin chains. This is necessary for normal hemoglobin formation. For the genetic origin, this involves deletions or mutations in the genes encoding alpha 1 and alpha 2 globin chains. These genes are located on chromosome 16. For the gene details, each person has 4 alpha globin genes. 2 are located on each chromosome 16. The severity will depend on how many of these 4 genes are affected. So if there's a 1 gene deletion, they are generally a silent carrier. 2 deletions, they have the alpha thalassemia trait. 3 deletions, they have the hemoglobin H disease. And 4 deletions means they have hydrops fatalis, which is usually fatal. Thalassemia syndromes result from a heterogeneous group of genetic mutations that disrupt normal globin chain synthesis. These mutations affect various stages of gene expression. So the first one is there's a reduced or absent transcription of mRNA. So mutations in the promoter or regulatory regions of globin genes. This leads to a decreased or no transcription, and that means there's less mRNA for globin production. Then we also have mRNA processing errors. So this could be mutations that affect splicing, capping, or polyadenylation of pre-mRNA. This results in unstable or non-functional mRNA, which reduces globin synthesis. We also have translation errors. So we have mutations that interfere with ribosome binding or translation initiation. This produces inefficient or defective translation of the mRNA into globin proteins. Then we have deletion of 1 or more globin genes. This is especially common in the alpha thalassemia. So deletions will lead to a complete loss of gene function, eliminating production of that globin chain. So the overall impact, all these mutations result in reduced or absent synthesis of 1 or more globin chains. This imbalance in globin chain production leads to the various clinical forms of thalassemia, ranging from silent carriers all the way up to those life-threatening anemias. For pathophysiology, there is underlying causes of the symptoms. So clinical features of thalassemia is primarily going to arise from two different problems. The first one is a reduced or absent production of those globin chains, which is going to lead to a decreased hemoglobin level, which can cause hypochromic microcytic anemia and will also cause red blood cells that are less efficient at oxygen transport. Could also be from imbalanced globin chain synthesis, and this is when one globin chain is produced normally and the other is absent or reduced. So the excess unpaired chains precipitate inside the red blood cell precursor. This will lead to ineffective erythropoiesis, and this results in hemolysis and further anemia. So the clinical presentation of beta thalassemia is going to depend on a number and type of mutations affecting the beta globin genes. These syndromes range from completely silent to life-threatening. So the beta thalassemia silent carrier, this is caused by a very mild mutation in a single beta globin gene, so a heterozygous state. There are no clinical symptoms and no significant hematologic abnormalities. This is often undetected unless they are tested genetically. The beta thalassemia minor trait, they are heterozygous for a beta plus and a beta 0 mutation. They have mild microcytic hyperchromic anemia. Their red blood cells are small and pale, and there is no significant clinical symptoms at this part, and they are often discovered during this routine blood test or in a carrier screening. Beta thalassemia intermedia, this is caused by either two mild mutations or one mild and one severe mutation. This results in mild to moderate hemolytic anemia. The red blood cells are microcytic and hyperchromic. Clinical symptoms vary, but they could include fatigue, jaundice, and splenomegaly, and it does not usually require regular blood transfusions. And then we have beta thalassemia major, also known as Cooley's anemia. This is caused by two severe mutations. This leads to severe hemolytic anemia. Red blood cells are microcytic and hyperchromic. This will usually present early in life with severe symptoms such as growth delay, bone deformities, pallor, and an enlarged spleen. Patients are dependent on regular blood transfusions for survival. So some simplified clinical classification of the symptomatic beta thalassemias. So we have transfusion dependent and non-transfusion dependent. So transfusion dependent thalassemia, this includes severe forms such as beta thalassemia major. These patients require lifelong regular blood transfusions to manage anemia and maintain quality of life. Whereas the non-transfusion dependent thalassemia, this includes milder forms such as beta thalassemia intermedia, and these patients do not require regular transfusions, although occasional transfusion support may be needed during certain periods of stress or even illness. All right, so beta thalassemia minor. This occurs in individuals who are heterozygous for a mutation in the beta globin gene. This means they carry one normal beta globin allele and one mutated allele. As a result, there is a partial reduction in beta globin chain production, but the body is typically able to compensate enough to avoid any significant clinical symptoms. Hemoglobin levels in affected individuals are usually slightly low, reflecting a mild anemia. So despite this, most patients are asymptomatic and are often only diagnosed during routine blood test or genetic screening. Red blood cell morphology will show typical signs of microcytic and hypochromic anemia. Specifically for laboratory findings, we'll often reveal an MCV that's below 75 femtoliters and a mean cell hemoglobin, or an MCH, below 26 picograms. So bone marrow examination, if it is performed, it will typically show mild to moderate erythroid hyperplasia, indicating a compensatory increase in red blood cell production. However, bone marrow studies are not usually necessary for diagnosis for beta thalassemia minor. For beta thalassemia major, like mentioned earlier, as it's also known as Cooley's anemia, this occurs in individuals who are homozygous for beta globin gene mutations, meaning both copies of their beta globin genes are defective. This leads to a marked reduction or complete absence of beta globin chain production, which then results in severely decreased hemoglobin levels and profound chronic anemia. Red blood cell morphology in beta thalassemia major is severely abnormal. There is marked microcytosis and hyperchromia, along with anisocytosis and poikilocytosis. This is commonly observed. We'll see abnormal cell types that will include target cells, teardrop cells, and elliptocytes. The peripheral blood smear may also show signs of immature red cells, such as polychromasia, in the presence of nucleated red blood cells, or NRBCs. Inclusions with red blood cells are also frequently seen. These may include basophilic stippling, Howell Jolly bodies, and Pappenheimer bodies, which reflect ineffective erythropoiesis, splenic dysfunction, or both. Patients with beta thalassemia major typically present in early childhood with severe anemia, failure to thrive, skeletal deformities, and splenomegaly. Without treatment, the condition is life-threatening, so regular blood transfusions are necessary to maintain adequate hemoglobin levels and prevent further complications. The only curative treatment currently available is hematopoietic stem cell transplantation. However, this option is limited by donor availability and the associated risk. So supportive management often includes lifelong transfusions and iron chelation therapy to prevent iron overload from repeated transfusions. For beta thalassemia intermedia, this is a clinical designation used for individuals whose disease severity lies between beta thalassemia minor and beta thalassemia major. So patients with this condition experience an imbalance of alpha and beta globin production, but it is less severe than beta thalassemia major. Unlike major forms, regular blood transfusions are not required to maintain acceptable hemoglobin levels or the quality of life. Hemoglobin levels in beta thalassemia intermedia typically range between 7 and 10, which results in a moderate chronic anemia. While the anemia is not as severe as a beta thalassemia major, it can still lead to fatigue, mild jaundice, and splenomegaly over time. Red blood cell indices are abnormal, so the MCV usually falls between 50 and 80 femtoliters, and the MCH is usually between 16 to 24 picograms, which reflects microcytic and hyperchromic red blood cells. Patients may exhibit mild clinical symptoms and complications over time, such as delayed growth or iron overload, even without transfusions, and this is due to the increased intestinal iron absorption. So management will typically focus on monitoring, occasional transfusions during stress or illness, and iron regulation if needed. Screening for beta thalassemia minor. So due to high worldwide carrier frequency of beta thalassemia mutations, screening programs have become an important part of global public health efforts. Early identification of carriers helps in preventing severe cases through genetic counseling and prenatal diagnosis. Mass screening initiatives in countries such as Italy and Greece have demonstrated success in significantly reducing the number of children born with beta thalassemia major. These programs combine carrier detection with prenatal diagnostic techniques, allowing couples at risk to make informed reproductive decisions. Parents who are both carriers of beta thalassemia mutations face a 25% chance with each pregnancy of having a child affected with beta thalassemia major or intermedia, depending on the specific mutations that are involved. Potential carriers of beta thalassemia minor can be initially identified through routine blood tests. Findings typically include a mild decrease in hemoglobin concentration, a reduced MCV, and an increased level of hemoglobin A2. However, it is essential to exclude other causes of microcytic anemia, such as iron deficiency, before confirming a carrier status of a patient. We're going to switch gears to alpha thalassemias. So the most common genetic defect in alpha thalassemia are large deletions that involve one or both of the alpha globin genes. These deletions reduce or completely eliminate the production of alpha globin chains, leading to various clinical syndromes depending on how many alpha globin chains are affected. For alpha thalassemia minor, this is caused by the deletion of 2 alpha globin genes, typically one on each chromosome. This genetic defect leads to a reduction in alpha globin chain production, but enough alpha chains are still produced to avoid severe symptoms. Clinically, individuals with alpha thalassemia minor are usually asymptomatic. Laboratory findings will show a mild microcytic anemia, which is going to be characterized by an MCV less than 80 femtoliters and an MCH less than 27 picograms. Despite these changes, patients generally do not yearly experience any significant health issues. For hemoglobin H disease results from the deletion of 3 alpha globin genes. This leads to a significant deficiency in alpha globin chain production. This severe imbalance causes the formation of beta globin tetramers known as hemoglobin H. So clinically, hemoglobin H disease will manifest as a mild to moderate chronic hemolytic anemia with hemoglobin levels typically ranging from 7 to 10. Reticulocyte counts are elevated and they're usually between 3 to 10%. This will reflect increased bone marrow activity to help try to compensate for the anemia. So, however, the clinical severity and laboratory findings can vary widely among patients. For bone marrow studies, you'll typically reveal erythroid hyperplasia, which is an expansion of the red blood cell precursor as the marrow attempts to keep up with the demand for new red cells. The red blood cell morphology will show microcytic and hyperchromic cells along with poikilocytosis, target cells, and bizarre shapes. These abnormal red cells contribute to the hemolytic process. Hemoglobin H is particularly susceptible to oxidative damage, which can lead to gradual precipitation within circulating red blood cells. This forms inclusion bodies of denatured hemoglobin, which can be observed under the microscope and contribute to the shortened lifespan of the red cell. Bart's-Haydrop's fatalis syndrome. So this is a syndrome that is caused by the complete absence of alpha globin chain production. This is due to the deletion of all 4 alpha globin genes. This results in a severe imbalance where no normal hemoglobin can be formed. So clinically, this condition is incompatible with life. Typically, this will lead to death in utero or shortly after birth. The absence of alpha chains means that the fetus produces abnormal hemoglobins, such as hemoglobin Bart's, hemoglobin Portland, and hemoglobin H, which are, none of those are effective at oxygen delivery. For red blood cell morphology, this is characterized by microcytic hyperchromic anemia with a high reticulocyte count and the presence of nucleated red blood cells in the peripheral blood, which would indicate a severe stress on the bone marrow to produce red cells. Bone marrow studies typically show marked erythroid hyperplasia with expansion of the marrow cavity as the body attempts to compensate for profound anemia. The prognosis for the mother carrying a fetus affected by hemoglobin Bart's-Haydrop's fatalis can be serious, with risk including toxemia and severe postpartum hemorrhage due to complications arising from the affected pregnancy. Hemoglobin S thalassemia. This is a genetic condition that results from the co-inheritance of sickle cell mutations, so hemoglobin S, and thalassemia mutations affecting the beta globin or alpha globin genes. This combination leads to variable clinical presentations depending on the specific mutations that are involved. So in sickle cell anemia with alpha thalassemia, individuals inherit 2 abnormal beta globin genes for hemoglobin S, along with an alpha thalassemia haplotype. This form is sometimes referred to as S, alpha plus thalassemia and is fairly common in certain populations. The presence of an alpha thalassemia can modify the severity of sickle cell disease. In hemoglobin S beta thalassemia, one parent contributes a hemoglobin S gene and the other parent contributes a beta thalassemia gene. This results in a compound heterozygous state with clinical features that differ from classic sickle cell anemia. There are 2 subtypes. First one is hemoglobin S beta plus thalassemia, where there is reduced but not absent beta globin production. And then we have hemoglobin S beta 0 or null thalassemia, and this is with absent beta globin production. So laboratory findings will differ between these 2 conditions. In hemoglobin S alpha thalassemia, anemia is generally milder than in sickle cell anemia alone, and this is due to the reduced amount of alpha globin chains, which affects hemoglobin polymerization in sickling. In hemoglobin S beta thalassemia, patients can be distinguished from those with sickle cell anemia by the presence of microcytosis, splenomegaly, an elevated hemoglobin A2 level, and a hemoglobin A level that is less than the hemoglobin S level. These features reflect the underlying thalassemic mutation affecting the beta globin production. Hemoglobin C thalassemia. This is a compound heterozygous condition involving 1 gene for hemoglobin C and 1 for beta thalassemia. This combination leads to clinical and laboratory features that reflect both hemolytic anemia and the thalassemic red blood cell abnormalities. So clinically, patients will experience moderately severe hemolysis and splenomegaly. For laboratories, we will see hyperchromia, microcytosis, and a high number of target cells, which are characteristic of thalassemic red cell morphology. The hemoglobin electrophoresis pattern will vary depending on the specific beta thalassemia gene defect. In cases where there is minimal or no beta globin chain production, patients show a higher concentration of hemoglobin C, which influences the severity of symptoms and the degree of hemolysis. Hemoglobin E thalassemia. This results from mutations that cause decreased production of hemoglobin E, which is a variant of the beta globin. This condition combines features of both hemoglobin E disease and beta thalassemia, which leads to a spectrum of clinical severity. So severe forms of hemoglobin E beta thalassemia present with hemoglobin concentrations as low as 4 to 5. These patients often experience significant anemia and complications requiring regular transfusions and are therefore classified and managed as transfusion-dependent thalassemia. There's also mild to moderate forms of hemoglobin B beta thalassemia. Their hemoglobin levels range from 9 to 12 and sometimes even down to 6 to 10 respectively. Patients with these forms generally have less severe symptoms and are classified and managed as non-transfusion dependent thalassemias. So a thorough individual and family history is going to be essential in evaluating patients that are suspected of having thalassemia. We'll need to make sure there is particular attention that is paid to the ethnic background of a patient, as certain populations have a higher prevalence of specific gene mutations that are associated with thalassemia. This knowledge will help guide diagnosis and genetic counseling. Clinically, patients may present with pallor reflecting anemia and jaundice caused by ongoing hemolysis of abnormal red blood cells. Splenomegaly is also a common finding resulting from the sequestration and destruction of defective red blood cells. So there is excessive extravascular hemolysis and compensatory extramedullary erythropoiesis, where the red blood cell production is occurring outside of the bone marrow. In chronic or severe cases, skeletal deformabilities may develop due to massive expansion of the bone marrow cavities. This is particularly in the skull and facial bones as the body attempts to increase erythropoiesis to try to compensate for that anemia. So it is crucial to distinguish thalassemia from iron deficiency anemia and other causes of microcytic hyperchromic anemia. Proper differentiation helps avoid unnecessary tests, inappropriate treatment such as unwarranted iron supplementation, and delays in correct diagnosis and management. A detailed clinical history, including family history of anemia or thalassemia, provides important clues. The laboratory evaluation plays a role in the differential diagnosis, of course. So for laboratory features, for the red blood cell counts, which are typically normal or elevated in thalassemia, but they are generally low in iron deficiency anemia. For the peripheral blood smear, so we're going to see microcytic hyperchromic red blood cells with characteristic shapes and inclusion bodies in thalassemia. The serum ferritin, serum iron, total iron binding capacity, and transferrin saturation, and maybe even some other iron studies, can help evaluate iron status and help distinguish iron deficiency from thalassemia. We can also look at the transferrin receptor and zinc protoporphyrin levels, which may also aid in the differentiation. So accurate diagnosis ensures appropriate treatment and genetic counseling for our patients.